Thank you, Nicole, and welcome everyone again. This is the Health Planning Council meeting for June. Happy to see you all. I'm Lara Parilla, Community and Academic Partnership Manager with Cayuga Health Partners. We're going to start today's meeting with approving May's minutes, and then we'll move into a presentation that John and I will be giving to you about the Medicaid 1115 waiver amendment. So before we start that, first I would like to ask advisory board members if you have any changes or edits to the May minutes. Okay. Can I have a motion to approve the May minutes?
Move.
And, okay, we have a first and a second. Thank you. All in favor of approving May minutes? Anyone oppose or abstain? All right, minutes are approved, and I think we can move right into presentation, right, Nicole?
Or doing announcements first.
Oh, sorry.
It's okay.
Um,
And I can get us started.
yeah.
Just
Thank you.
some quick announcements. So on the agenda for today, I just had upcoming meetings. Our next long-term care committee meeting is August 2nd at noon. Our community health and access committee meeting for June was actually, we had the community health improvement meeting on this past Friday at the library in lieu of the committee meeting because it was a collaboration. So I know many of you were there, so glad to see faces, and Sam can talk a little bit more about that during announcements. So the next community and health and access committee meeting will be September 6th at noon. And then tough stuff subcommittee, we were going to have a meeting this month, but we're going to have to reschedule that due to unforeseen circumstances. But we're also going to have our next meeting as well on September 5th at noon. And then I also just, I usually do a community health and resource network for those who don't typically come to these meetings. That is a project that both Cayuga Health and Human Service Coalition have partnered with to connect healthcare providers and community-based organizations to better serve our community members and get them connected to different resources. So just want to give an update that we have, we're really in it in our phase 1B. We've moved past the development stage and we're now onboarding those community-based organizations, testing data, and hopefully we'll get into the launching and going live where community members can be referred on the platform across the network and get them connected into important resources through other community-based organizations or healthcare providers if that is what they need. So I think that's all I have for today.
Thanks, Nicole.
Nicole, have you set the date for the next executive committee meeting yet?
Yes, that you have a calendar invite for that, Frank.
Thank you. Thanks.
Okay, so I will just echo Nicole's update about our gathering that we had on Friday for the Chai Tompkins process, which is our community health improvement process. And thank you to many of you who were there. It was really great to have many community partners together and fill the room at the library. So this was meant to be our kickoff for the process, which will take place over the next year and a half or so, and actually the wrap up of phase 1. And so we went through, the different steps and planning that we've been doing over the past 6 months. And then we closed that with our community visioning process that we did. And we got input and feedback from the community, and it resulted in a community vision statement that will guide the process. So I will go ahead and share what we currently have for that statement with Nicole so that she could send it out fully to this group as well. But it's nice. It encompasses a lot about our community. and is aspirational as well. So we will be moving into phase 2 of this process. There are 3 phases. And the next phase is titled Tell the Community Story. And it will really be involve 3 different parts, a community partner assessment, a community status assessment, which is really like the more traditional community health assessment, where we look at different data from the state based on our county information, and do some more local data collection as well. And then community context is another piece that we'll look at giving context to that data about our status of health in the county. So we're excited about moving into that, and like I usually end my updates, just stay tuned. And we will keep this group especially posted. And Nicole and HSC have been really great partners in moving this process along. So I appreciate them and thank them for partnering on, piggybacking on meetings and that sort of thing, so that we are prioritizing our time together. So that's all I have for the moment. Thank you.
Thanks, Sam.
I see.
Fernanda?
Yeah.
Hi, good morning, or afternoon. So I just want to let everybody know the Transportation Council is currently in the process of updating our 20-year long-range transportation plan. And it's an opportunity to kind of highlight or certainly mention the interaction between health and transportation and lifestyle. And we allude to that in the plan. I encourage you to take a look at it. And if you have specific language you want included, or programs or initiatives or something like that, let me know. Send me a message. We're in a sort of a outreach and information gathering stage. So this is the time to communicate with me. Any good ideas? I'd love to consider them. I think this is an area that could use a little more attention, and this type of lifestyle change on a day-to-day, the way people move around can have huge health benefits, and it's something, it's another place to promote that. So I'm going to put on the chat a link to the update page. We have a small survey there, but you can reach the plan itself if we want to take a look at what we have now, and for your information. So thank you.
Thank you, Fernando. Do we have any other announcements, updates? Okay, I think I gave that enough awkward silence.
Yeah.
All right, so I think now we can transition. Did I miss anything, Nicole? Okay, awesome. I will share my screen while John introduces our presentation.
Okay, well, great. Thank you, Lara, and good afternoon, everyone. I'm John Mazzello. I'm the Deputy Director at the Human Services Coalition, and I'll be providing this presentation for you, along with Lara, who already introduced herself a few minutes ago. Today, we're going to be talking about the Medicaid 1115 Waiver Amendment, and we've subtitled it What We Know and What We Don't Yet Know. And, for some of you who've been involved in some of these discussions, this may be a little bit old hat. And for others of you, this may be the very first time that you're hearing about some of these things. And so our hope is that we can get everyone to a kind of a common level of understanding, and hopefully end the session today with some time for discussion and question and answer, or some of the planning type of work that this group really likes to dig into. Lara, can you go to the next slide? Yeah, thanks. So today we'll talk about what is Medicaid 1115. You hear this floating around. What exactly are we talking about? What is New York Health Equity Reform, which is the name of the most recently adopted or approved waiver amendment? What are social care networks, which is a component of New York Health Equity Reform? Who will they serve? What are the types of services that will be available? What will it be like for Medicaid members and for the community-based organizations that are participating? How does this whole thing get funded? And what might be some of the opportunities to build capacity locally and regionally? You see there it says CBO interest and capacity survey results. This will be based on two methods of data collection that have occurred over the past several of months by two applicants for that social care network role. And for full disclosure, both Lara and I are involved in in each of us one of these applications. And so for me, I am a board member of the Care Compass Network, which is based down in Binghamton. And that is an applicant for one of the social care networks, or for the social care network for the Southern Tier region. Lara, do you want to share your affiliation here?
Sure, yeah, my affiliation is through the second applicant, and that is the former DSRIP PPS through Bassett Healthcare. They're called the Leather Stocking Community Health Partners. And it's a collaborative proposal with Cayuga Health and Cayuga Health Partners specifically, and Cornell University's Master of Public Health program.
Thanks, Lara. So the way we've structured this presentation, we're not going to be talking very much, if at all, about the particular applications that different entities are have put together to play a role in this Medicaid 1115 waiver project. We wanted to provide you with information that's going to be relevant to Tompkins County, relevant to your organizations, relevant to you as community members, regardless of which entity is selected as the social care network lead. However, we did just want to share that we part of why we know a little bit about what we're talking about today is because we've been involved in some of the application processes. But what we'll share at the end there is some results of the work that these entities have done to gather information about the readiness of organizations and the capacity in our communities to respond to what the state has put out around what this project looks like. And then, as I mentioned, we'll wrap with a discussion or Q&A, or just time to talk about what this might mean, or what there may be opportunities to bring to the Health Planning Council in the future. I'm gonna pop ahead to the next slide there, Lara. Thank you. So let's start with the basics. What is a Medicaid 1115 waiver? So I just have copied here the language from Medicaid itself. So Section 1115 of the Social Security Act gives the Secretary of the Health and Human Services the authority to approve experimental or pilot or demonstration projects for Medicaid. And so these demonstrations can basically waive, as the name says, waive some of the standard rules for Medicaid to allow states to try something out, to allow the federal government to see what works and what doesn't work, to figure out some different approaches to trying to support the Medicaid population. New York State has had a waiver in place since 1997, and it regularly extends that waiver. Most recently, the waiver itself was approved back in April of 2022 for a 5-year period. There's various components of New York State's Medicaid 1115 waiver. We're just going to be talking about one part of it, but there are other components that touch on various ways that Medicaid is delivered through New York State. Lara mentioned earlier the phrase DSRIP, or the acronym DSRIP, that stands for Delivery System Reform Incentive Payment. That was a previous waiver project that ran in New York State from 2015 to 2020-ish. And that was a previous effort to try to improve quality of care for people who are supported by Medicaid, to reduce unnecessary hospitalizations, unnecessary emergency room visits, and to reduce the overall cost of providing Medicaid, particularly to individuals who have significant health needs or who are, have significant costs associated with their care. So that's a previous iteration. If you have heard of DSRIP or Medicaid 1115, that may have been the context in which you've heard of it. And that ran and ended a few years ago. So there was a conversation about a DSRIP 2.0. That's not exactly what ended up happening, but certainly what we're going to talk about the rest of this hour is based on the learnings from DSRIP as well as from other states' Medicaid 1115 waiver projects. And I'll turn it over to Lara to talk more specifically about this particular one.
Thank you, John. So our current waiver is called the New York Health Equity Reform, and it covers a 3-year period from April 2024 to March 2027. It was supposed to be a 5-year period, but it took some time for the approval from CMS to go through, but it was approved in January, and it has some overarching goals that include advancing health equity, specifically among Medicaid beneficiaries, improving health coverage, access to health care, and consistent provision of high-quality services for Medicaid beneficiaries. And then overall, the waiver is attempting to achieve statewide accountability for all of these goals. And in order to achieve these goals, there are 4 new initiatives. We're going to spend the majority of today's presentation talking about the first one, which has the majority of the funding from the waiver dedicated to building reliable networks of community-based organizations to better enable health-related social needs screening and delivery of social care services, specifically by CBOs, and it's through social care networks. So that initiative is called HRSN, or Health-Related Social Needs. The second initiative is the Medicaid Hospital Global Budget Initiative. And this is specifically for safety net hospitals in the Bronx, Kings County, Queens County, and Westchester County. So Kings is Brooklyn. And that is to stabilize those safety net hospitals. There's also an effort to strengthen the workforce so that there is more availability of healthcare practitioners who accept Medicaid and can serve beneficiaries. And that will be achieved through a few different programs, one of which is a loan repayment program. There's going to be career pathways training, and there will be organizations set up called workforce investment organizations. We are not going to get into the details of these, but there is about a 200-page document that includes more information about how New York State will go about strengthening the workforce. And then lastly, the state, in order to achieve the accountability that I referenced earlier, is setting up a statewide entity called a Health Equity Regional Organization. Kind of doesn't sound like it's statewide because it's called a regional organization. I think initially it was supposed to be regional organizations, but now there will just be one. And they will be working with the social care networks to develop these regionally focused approaches to reducing disparities, advancing equity, and supporting the delivery of HRSN services. That request for application has not yet been released. So there's still a lot of question marks about how that particular entity will function and how it will interact with the social care networks. I'll turn it back to John.
Sure, thank you. So there's a couple other things that are included in the waiver, but that we are also not going to focus on during this presentation. The first is there are some funds and some capacity being set up around substance use disorder services planning, and particularly related to healthcare IT, information technology, and what that might look like. Some changes to enable continuous Medicaid eligibility for children up to age 6 without having to recertify. And then importantly, but not part of this presentation, Medicaid provider rate increases to keep Medicaid rates at least 80% of Medicare rates for services. So those are other things that are included in that waiver that was negotiated with the federal government between New York and the feds, but that's not part of our presentation today, but we did want to share that. Larry, you can go to the next category here. So for the remainder of the presentation, Lara and I are going to kind of go back and forth. I'll share what we know, and Lara will give a little bit more about sometimes what we should be thinking about, or what we don't know, or how might this look in the future. As we talked about earlier, a lot of what we know about the social care networks is actually based on the request for application or request for proposals that the state put out for the administration of social care networks as a social care network lead in the different regions of the state. So that is where much of the knowledge about what's happening is coming from. As Lara mentioned, the HERO still has an application to come out that will maybe explain that more. And then there will be a number of other documents and guidance materials for the community-based organizations that will end up providing the services. So you'll see that there's a lot known about the social care networks, and less so about some of the other levels of this organizational structure. But to start with the social care networks. So New York State, and we've talked about this. I feel like I've presented on this, or we've talked about this at the Health Planning Council many times, the importance of health-related social needs, or what we often have called social determinants of health, those factors that affect a person, that could affect a person's health and well-being, but that aren't clinical or medical factors, or factors related to their individual physical or mental health. And so New York State recognizes that, and they are understanding that those health-related social needs, those other social factors, those other needs can have a greater impact on your health outcomes than your medical care alone. And there's a direct connection between these needs and the health inequities that are affecting various groups and individuals within our healthcare system. So their goal through this project, the state's goal through this project, was really to identify health-related social needs and in individuals and in groups, and provide services to meet those needs, understanding that can improve health and reduce health disparities. Go to the next slide, Claire. Thanks. So the approach that New York State has taken to trying to respond to these health-related social needs is to create a regional approach, to think about, not just at the very local level, but also not just at the state level, but really think about how regionally we might address some of these needs in a coordinated way, working together to build up social care services. The state is really emphasizing services provided by community-based organizations, which they are really emphasizing is a local, not-for-profit 501c3 organization. And in various places, the state is also really emphasizing their interest in smaller organizations rather than larger organizations providing that service. There really is a focus on organizations that are most closely connected to the individuals, the ones that are most closely on the ground, the ones that are not, very, very large, but the ones who really can be supported by building this out. And there is a big emphasis in the social care network proposals around data sharing. So facilitating the exchange of information facilitated by a technology in common across the organizations that are working together. And so that whole regional approach that's coordinated, sharing data, working on services, that will be known as the social care network. You go to the next slide, Claire. Okay, so I just want to give you a sense of what the regions are that we're talking about. So here you can see the state broken out by region. That New York City is broken up. It's one region broken up into 4, potentially up to 5. It's region 4 broken up into multiple leads that may coordinate those networks. But you can see region 6 is the southern tier, includes Broome, Shenango, Delaware, Otsego, Tioga, and Tompkins counties. If you were someone who was familiar with DSRIP, that previous iteration of Medicaid reform and 1115 waiver work in Tompkins County, you'll notice that region is different from what our region was during that project. So we have from our southern tier region, carved out has been Portland, Chemung, Steuben, and Schuyler counties, and added in is Otsego County. So this region is not exactly the same as it was under DSRIP, under the previous version. You'll also notice that, you know, if you start doing the math or just thinking about the counties, this is a small region. It is one of the smallest population regions in the state, how they've broken it out. So there's been a little bit of an adjustment. There was, I think, a lot of conversation in the lead up to the announcement of the social care networks around what might the regions be and how flexible is it. It does appear like the state is going to hold to these, but they do reserve the right to change the regions. But it is a little bit different. It's going to be a smaller region, a little bit more of a compact area and population center than it had been under previous iterations. I'll pass it over to Lara to talk a little more.
Thanks, John. So John mentioned that an important part of the social care networks is to facilitate the flow of data or information exchange between different entities that need that information to provide services. So I'm not going to walk through this entire workflow, but just wanted to point out a few parts of it that are important to consider. So first, here at the bottom left box, where it says social care network, there will be a lead entity in each region that develops a network of community-based organizations that are all using the IT platform, the shared IT platform for that region. And that platform will be receiving information from various sources, but through the regional health information exchanges. So there will be actually a bi-directional exchange of data in terms of member information, including their eligibility for enhanced services or level 2 services, whether they've been screened, whether they've received a referral. This is where all of the information that is inputted by community-based organizations when they are providing services will go back to the health information exchange, and then information that is coming from the managed care organizations around member eligibility for services will be flowing back down to the social care network IT platform. There is also what's called social care claims that the social care lead entity will be responsible for generating. And that is what will enable the community-based organizations to get reimbursed for the eligible services that they provide. So those claims go to the Medicaid managed care organization that individual is a member of, so that they can capture that information and provide per member per month payments, which is not reflected on this data flow diagram, but the managed care organizations will be responding to those claims through per member per month payments. And then lastly, there is information about performance that goes back to New York State, and specifically the Health Equity Regional Organization will be a part of receiving that information and aggregating it to look for trends and opportunities for improvement. So there's still some questions around who will be the lead entity. We probably won't know for at least another month or possibly more. There's still question marks around whether other state and local agencies will have access to the data that is generated in the social care network platform. And then, of course, there's also question marks around what will be besides being able to receive quarterly performance reports from the social care network, how else will the social care networks be expected to interact with the HERO, and in what ways will they be supported by the statewide agency? And I will turn it back to John.
Thanks. So, you know, already you're starting to see where some of the questions are. And one thing that I think has been, notable for me, and I think if any of you have been involved in the DSRIP work before, you will get a sense as well, I think, of how much more specified the state is being, or prescriptive the state is being around what will happen through this process. So where in the previous iteration of 1115 waiver, there was room for innovation, there was a lot more room for regional flexibility. The state is being much more descriptive or prescriptive around what is going to happen in each of the regions. That's partially why, regardless of which entity is selected as the lead, the things that we're talking about now, these eligibility criteria, the services, those will be consistent regardless of who the administrator of the facilitation, the logistics provider is. And that's a little bit different. There will still be work at the regional level to identify needs and capacity and priority, but there is a far narrower band of work that is specified under this program. So who will the social care network support? And the easy answer is Medicaid members, of course, but it's a lot more complicated than that. So the waiver is going to define exactly which social care services are reimbursable and who is eligible for those services. And what New York State is claiming is that they will focus on services where there's, quote, a strong evidence base on the impact of that social care service on health. So you may find that an intervention or a service that you really think has a big benefit to health is not listed in this menu of eligible things, and that's true. There are a number of services in there, but they are not the exhaustive list of all interventions that have an impact on health. Would you go to the next slide? So the way things will work under the social care network is if a Medicaid member has an identified health-related social need, and if they meet specific eligibility criteria, then they will be able to get a referral or be able to access what the state is calling enhanced social care services that can be reimbursed under the waiver. If they don't meet those eligibility criteria, then they still can be navigated to pre-existing services that are already available, but that will be under the same funding and the same model of payment as they currently are. So if I'm an individual who doesn't meet the criteria, but I still identify as having a need, there will be an opportunity to connect me with those services, but there won't be any additional Medicaid money for that. Those services may not even be part of the network. It may be out of the scope of what the social care network is providing. So really the key for this is who is eligible and what are their needs. And we'll talk about that now on the next slide. So there's a number of different ways that someone can be eligible for enhanced services. And the state has defined it in this way. A member who is enrolled in Medicaid managed care, so you've got to be in managed care and not under straight traditional Medicaid. So enrolled in Medicaid managed care who screens for an unmet health-related social need and then further meets one of these criteria. And so a Medicaid high utilizer, someone who is enrolled in a health home, a person who is pregnant or up to 12 months postpartum, an individual who is a post-release criminal justice involved person who has some chronic conditions, juvenile justice involved, or youth in foster care, or those in kinship care, children under the age of 6, or children under age 18 who have chronic condition, people with a substance use disorder, folks with an intellectual or developmental disability, or folks with serious mental illness. And these will be have already been started to be defined in more detail how you actually would do that. But so this is many people on Medicaid, but just want to caution you, it's not everyone who is on Medicaid. So there's just defined this fairly widely, but not everyone. If, again, I want to just really stress, if someone doesn't meet this criteria, but they identify for a need, they still can be referred to other programs. But again, that may not be covered by the social care network or the Medicaid funding through this waiver amendment.
Thanks, John. And I'll just add, linking it back to the slide that I previously showed with the Medicaid managed care organizations as part of that data flow. This information around eligibility will be provided by the Medicaid managed care organizations through the health information exchanges and our local or our regional health information exchange, many of you may be familiar with, is called Healthy Connections, and then back to the social care network. So that is how the community-based organizations will know whether the individual that they're working with, who is a Medicaid member, is actually eligible for these enhanced services. So what about people in our community who are not currently on Medicaid insurance? So there's about a little over 4 in 5 community members in Tompkins County do not have Medicaid as their insurance. And lots of questions have come up around how will this new system benefit those individuals? Especially because we know from local experience that there are many community members who have unmet social needs, but they are not receiving Medicaid. So what we do know is that this particular waiver funding can only be used to support approved activities, which John is going to go through in just a minute, and specifically for eligible Medicaid members. What we do know is also that this data information exchange system does have the capacity to capture information about individuals who are not receiving Medicaid. So all of that information can be added to the platform and aggregated, but what we don't know is whether there are going to be any restrictions around how we use the platform for people who are not on Medicaid, specifically to make referrals. So we're still awaiting guidance in that area as well. We keep talking about screening members for unmet needs, but we haven't talked more specifically about how that will be done. First, I'll share that many different entities will be eligible to screen individuals for unmet social needs, but they'll have to be a part of the social care network and also receive training on how to do it confidentially with privacy and compassion. Members are supposed to be screened once a year. If they're screened more than that, the entity who does the screening will not be reimbursed for that screening. And then lots of questions have been coming up around what kind of flexibility might there be in terms of using different screening tools. So for example, in Tompkins County, we're currently using a screening tool that was adapted from Health Leads, but New York State chose to use a slimmed down version of CMS's Accountable Health Communities social needs screening tool. So we do know that that will be required, that if we want to be a part of this network and get reimbursed for the screening, we have to use this New York State standardized version. Or, and this is a little fuzzy, it says a comparable tool that asks all the same questions. So what we don't know is, can we add additional questions or can we adjust any of the language? So we're still waiting for guidance on that. But I thought folks may be interested in seeing what those questions are. There are 12 questions altogether. The first section covers housing and utilities. So these questions are a little bit, include the same domains that we in Tompkins County have been asking community members about. But rather than yes/no questions, these are multiple choice questions or on a scale. So in terms of housing and utilities, we ask, what is your living situation today? The next question is about any problems that you might have in the place where you live. if in the last 12 months, electricity, gas, oil, or water has been threatened to be shut off in your home. There are a couple questions about food security within the past 12 months. Have you worried that your food would run out before you got money to buy more? Or how often does that happen? And the food you bought just didn't last and you didn't have money to get more. So in a way, what's nice about these questions is that it gives us a sense of the urgency level of the need because it's asking these questions on a scale. We also ask about access to reliable transportation and whether that's kept you from getting to medical appointments, meetings, work, or getting things needed for daily living. It asks, do you want help finding or keeping work or a job? Do you want help with school or training? And then 4 different questions about interpersonal safety. These questions are often asked in a healthcare setting as part of the social history, but are not currently included in the social needs screening that we're using in Tompkins County. So this would be something new that we would be required to add. Back to John.
Yeah, so now I'll just quickly go through what the state has indicated are the services that are reimbursable under the waiver. And they fall under a handful of categories, and they match up to some of the questions that were asked in the screener there naturally. So the first kind of service that's reimbursable is that screening itself. So just pretty basically, doing that screening of Medicaid members, and the goal for this program is that every Medicaid member is screened at least annually to assess their need for additional supports. Go to the next slide. In addition to the screening, there are services that are falling under the navigation and case management banner. So that first one up there, navigation case management, this is for folks who would have identified as in need of a support with a social care need, but they maybe aren't eligible for the expanded supports, or they decline them. So they can still receive a link or a referral or a connection to existing local, state, or federal programs. But that wouldn't be what is considered an enhanced service under the waiver, but they still would be able to have that connection made. So that is going to have an opportunity to get reimbursed, but for the organization making that connection. The deeper version of that, the HRSN case management, the health-related social needs case management, that's going to be for folks who do fall into that eligible category with the need and are going to need a more in-depth kind of connection. So they might require case management or case coordination. They might need a little bit of a longer support. They may need different kinds of supports, including help with getting connected to benefits, connections to employment, other resources. This is more in-depth case management than just that linkages connection for the folks who aren't eligible for the enhanced. So just 2 different levels under navigation and case management. Are you eligible? Do you receive that fuller enhanced service and the potentially additional case management, or are you not and you really just need that connection? Next slide, please. Now we'll fall into kind of the focus areas, of which there are 3. So the first is housing. I won't go through all of these in much detail, but just to point out to you what the types of services will be under housing. Housing navigation, so support for really navigating the housing system and the different points where an individual may need support. Transitional support will be eligible. This could include things like moving costs, first month's rent, security deposits. So really valuable, important things for moving folks from, example, being unhoused to moving into housing, or moving from one location to a more appropriate location. Utility setup and utility assistance, including back payment. But that's going to be limited to folks who are also receiving rent or temporary housing assistance. Can you go to the next slide? Thank you. So as I mentioned, you can also receive rent or temporary housing assistance up to 6 months, but the state has put restrictions on who might be eligible for this. So individuals who are coming out of institutional care or a congregate living location, individuals who are Medicaid high utilizers, and who are homeless, and youth who are transitioning out of foster care or child welfare system. So this is going to provide some pretty significant support for folks, but not for everyone who might need it, particularly in Tompkins County. There'll also be the ability to provide pre-tenancy and tenancy sustaining services. So this would be support around helping people to avoid eviction, which we know in Tompkins County has been a developing kind of support that really can save you from having to move and need all that associated support. Go one more, please. There's a lot around housing, a little bit more here to talk about. Home remediation, which is going to be helping to fix up some things that are maybe affecting your health that are in the home, such as mold or pest infestation, or other things. And then home modification, which could include things like appliances or air conditioners or things like that to enhance the ability of a person to stay healthily in their home. And then one more service under housing, and that is, if you go to the next slide, medical respite. And so this is going to be a temporary support, particularly for individuals who are homeless that do not have an option when they've been discharged from say from the hospital, or otherwise would need hospital stay, an opportunity to provide them with a setting where that service can be provided that they wouldn't have in their normal living situation. So that's the housing bucket. Under nutrition, there's a number of services: nutrition counseling and classes, healthy meal prep, medically tailored meals, which can be delivered for up to 6 months. And this is an interesting one because the state has been, in my view, starting to narrow even further these definitions. So when the request for proposals for the social care network lead was put out earlier this year, medically tailored meal was actually home delivered meal. And then it became a medically tailored meal, which is a different situation. So it was previously just a delivered meal to someone who needs it, and then it became something that is actually medically needed or clinically appropriate. And so they're starting even now, even before they really launched the program, to identify areas where they might be further defining what these services are. Another one that is kind of a growing in our region is the fruit and vegetable prescription. Again, another opportunity to connect people to healthier, more appropriate foods. Go to the next slide, please. Some more around nutrition, supporting the stocking of a pantry, particularly for children and pre or postpartum situations, and then cooking supplies. So you got the food. Also, here's some supplies to be able to prepare that food. And then I think just one more slide of the services. Yeah, the final one is transportation. So we've got housing, food, and transportation as our big focus areas. The final one is public and private transportation, particularly to connect people to the services that'll be provided in the other areas, as well as case management around that transportation. So as you can see, there's a number of services listed here. We are still waiting for more guidance on, exactly what that will look like. But this gives you a sense of the types of areas that the state is focusing on as those specific services. And again, if you remember the DSRIP days, if you were involved in that, where there was more opportunity for innovation, for you to propose what you think the community needs, we're not really seeing that at this point in the waiver process. I'll turn it to Lara now.
Thanks, John. So I think we touched on sort of what the member experience might look like, but this is a flow chart that I thought might help tie it all together. So starting on the left, there will be a number of different, hopefully in our community, opportunities for Medicaid members to interact with a healthcare provider or an agency whether it's in an office or in the community, where they can complete the standardized screening form. And after that form is completed, they would be asked if they have one or more unmet needs, they would be asked if they would like help with those needs. And if they do, there will be an opportunity for the organization that is providing navigation services to be able to find out whether they are actually eligible to receive the enhanced services that John just reviewed. And that's going to be based on the information that they're getting in the data platform directly from the managed care organization. So that's going to determine whether they will be navigated to existing services, if they don't meet the eligibility criteria. And if they do, they will then receive a referral to enhanced services. So it's not entirely clear yet what the timeframes would be for a member going through this process. That's certainly going to be one of the performance metrics, is how quickly the member is moved through this process. But that's another area that I think will be interesting to learn what those requirements will be. But then in terms of what the experience would be like as a community-based organization that wants to participate in the social care network, what we anticipate would be happening first, once the social care network lead entity is selected and a contract is signed, hopefully around October. That might be delayed, but after that contract is signed, the social care network lead will be reaching out to CBOs to better understand what kinds of supports they might need in order to meet the network participation requirements. So those include providing navigation or one or more enhanced service. So screening only is not sufficient. You have to also provide navigation or an enhanced service. You also need to maintain a coverage area within the zip codes in the social care network, hold not-for-profit status. There needs to be individuals in your organization that are designated to be points of contact and be trained in using the social care network platform. There will need to be a way to demonstrate cultural and linguistic competency, and a commitment to accepting referrals, providing services, and participating in the coordination of the delivery of those services. And then lastly, the SCN leads will be assessing whether, the CBOs will need to be able to assess whether they have capacity or any constraints in their capacity to provide services, and then be able to estimate their need for capacity building funding. So capacity building funding, or startup, sometimes we talk about it as startup funding, may include a direct investment in the CBO. So getting money to hire more staff who can participate in these activities. Whether it's upgrading what they're already doing so that they meet the service provision requirements, or if there just needs to be more people that are doing the screening and navigation work. Capacity building funds can also be used for the CBO to enroll in the data platform, and then also to participate in training or technical assistance. We are still waiting for more information from the state. It will probably be in the program manual about what that consent form will look like. So members will need to sign a consent form in order to participate in this service. We're still waiting for more information that describes the specifics of the services that John just reviewed with you, what kinds of documentation will be required of the CBOs after they interact with a Medicaid member. We don't know precisely what that would look like. And we also don't yet have a fee schedule. So we don't know what those reimbursements will look like for each of those services that we just looked at. We know that the fee schedule will be based on costs in the region. So there might be different fee schedules in different regions, but we don't yet have that. What we do know is that this is like the big picture view of how funding is going to flow. So starting with New York State up top, there will be, there's a total of $500 million going to those 9 regions, divided among those 9 regions that will go directly to the social care network lead entity. And that infrastructure funding includes funding for CBOs for startup and capacity building. Then there's funding that the social care network lead entity will receive in addition to the infrastructure funding. So there will be per member per month payments that should be used to reimburse the community-based organizations for screening and services. And then also social care networks that meet the performance criteria will also be eligible to get bonus payments. So the the per member per month payments and the bonus payments is what the social care network will use to pay directly pay the CBOs for the services that they deliver. So what we don't know yet is exactly how the capacity building funding will be made available to the CBOs, whether there might be an application process, and we don't know yet when those will be available. And this will be dependent on the social care network lead and whatever requirements New York State puts out for capacity building funding. We don't yet know what the per member per month amount will be that the social care networks will receive. And as I already mentioned, we don't have a fee schedule and we don't know when those payments will begin. Sorry to be the bearer of bad news on this slide. One other interesting thing that has come up around how things are going to work. So let's say there's a Medicaid member who is eligible for enhanced services and they live in Cortland County. But because they live close to Tompkins and maybe they work in Tompkins County, they interacted with a health or human services provider in Tompkins County. They are going to receive services from that community organization in Tompkins County. So how exactly is, because Cortland County is actually in a different region from the Southern Tier region, and Tompkins is part of the Southern Tier region. The question is, how is it that the Southern Tier region social care network will be able to pay for the services provided by that CBO in Tompkins County? So this is probably more complicated the way I'm explaining it than it needs to be, but there are some solutions to this problem, and that relates to information exchange through the health information exchange called Healthy Connections, and also through the State Health Information Network of New York. So we know that there's a data information solution, but we don't know yet how the CBO exactly will get reimbursed for providing services to a community member in a different county. And I think, as we all know, we live in a community where there are people coming from probably 5 or 6 different counties coming into Tompkins County to receive services. So this is actually, it's not going to be a one-off thing. This is actually going to happen quite often. So this is an area that I think a lot of the social care networks are very curious about, and hopefully there will be an easy solution to this. Okay, I know we're nearing the end, and I have a few more slides that I want to share with you that many of you actually contributed to providing this information, specifically to the group that submitted a proposal under Southern Tier Health Equity Partners. So that Bassett, Cayuga Health Partners, and Cornell University application. We reached out to organizations across the region, and there were a total of 59 responses. And of those organizations that responded, 30 of them provide services in Tompkins County. So I'm going to show you some information about the organizations that provide services in Tompkins County. So we asked the question, if startup funds were provided to cover the cost, to cover your costs until fee-for-service reimbursements were available, would your organization be able to provide, and then fill in the blank is each of those different categories of services. So these are the results of those questions. So as you can see, 20 out of the 30 said, yes, we can provide screening, and almost as many said yes to navigation. A little over half was able to provide transportation services, half case management, and about a third housing, and a third nutrition services. So just to give you a taste of like what kind of capacity, at least for those who responded to the survey, have to provide these services to Medicaid members. Specific to transportation services, of the 16 organizations that said yes, we could provide transportation services, 10 said they actually can do the transportation, like the physical transportation from one point, from the member to health-related social needs services. And then even more said yes to, we can take care of reimbursing people or providing gas cards or bus passes for those individuals. So we might not be able to take people there, but we can help out with these other services. Here's the breakdown for housing services. We only had one organization that provides services in Tompkins that can provide medical respite. Many more were able to provide navigation, utility setup, etc. In terms of nutrition services, medically tailored meals was the area where we had the fewest number of organizations that could provide that service, whereas cooking supplies and nutrition counseling and classes, that was an area that we were able to meet the need more easily. And then lastly, there's some additional findings that John is going to share with you.
Sure, and this is our final slide, so we'll have about 10 minutes for Q&A and discussion. So similar to the work that Lara's group did, the Care Compass Network also conducted some information gathering as part of their application for the Social Care Network lead. And these are some summary of the findings that they shared with me from across the whole region. So some similar findings here. So first of all, understanding what the true cost of expansion is for organizations or for creating new service lines. So what will it cost with that setup and startup time? But then also, what are the actual costs of what it will really take to sustain that over time? And a question for organizations will be, does the fee for service that schedule, will that meet that cost? Will it break even? The intersection of transportation access and food insecurity was a big one that came up for organizations that responded to Care Compass Network survey or participated in their focus groups. That medical respite service as a pretty significant gap across the whole region currently, and what it would take to create that kind of service at the appropriate level. The identification that, we all know, right? There's insufficient, affordable, adequate, and safe housing in many of the areas of that region, and just organizational capacity funding to do more housing navigation, to provide more. I mean, it's not going to be enough. And what the note from Care Compass I received said, the social care network will need to work with planning agencies and local government and other stakeholders to understand the big picture and the specific challenges within each county. Similarly, transportation, especially in rural areas, is going to need a particular focus, especially to connect individuals with those other expanded services. And so understanding what's available and what's not, and what can be supported through the state money through this program and what can't be, and does that allow us to meet the need? And then finally, understanding our region as a whole, there needs to be both a rural and an urban strategy, and not just one that focuses on one kind of geography. Understanding that our rural and urban needs may be different, and how you would address those needs may be different. So with that, I think we are finished. Happy to take questions or just have conversation and discussion about what this all might mean for Tompkins County.
John, Bill Gilligan. Is there any demographic information about the population? How many people currently are on managed Medicaid? And would Healthy Connections be able to provide kind of a breakdown of how many of those people might meet some of the criteria that you said out of that population? And I'm talking not just for Tompkins County, but across the whole region.
Yeah, I don't want to, and Lara may have the numbers more readily available in her mind. I don't want to I
wasn't looking for specific numbers. I was just wondering if that data available to you.
Yeah, there are some estimates for that. I mean, we certainly know how many people are on Medicaid and managed Medicaid. And then I think, kind of going through those categories. So yeah, that is something that we could send around, unless you've got it, Lara. That is something, yeah, she's putting it in. She's putting it in the chat right here. So 13,000 on managed. And then I feel like I saw somewhere, and I could be wrong, but I felt like maybe up to 80% of managed Medicaid members could be covered by one of those. I'm not sure if that's the exact number, but that's what's sitting in my mind. So a pretty good chunk of those members could be in that other eligibility criteria.
Okay, thank you.
Thank you so much for the presentation, John and Laura. Do you anticipate healthcare organizations doing the surveys, or would they be just connecting those individuals with the CBOs?
You want to take that one, Lara?
Sure. I anticipate that providers in Cuba Health Partners Network will continue to, and more will continue to, more will add screening into their clinical workflows, and will be even more motivated to do screening now that there's this infrastructure around it, additional infrastructure, I should say. And my hope is that other healthcare providers choose to adopt the health-related social needs screening as well. But certainly New York State is not counting on healthcare entities to be the screeners, right? I think they were sort of included in that diagram as like optional. So I think that there's more emphasis on community-based organizations who have those close relationships with Medicaid members to be the ones that are screening. So I think it really might end up being county and region specific to really see what level of involvement healthcare providers will have. And I don't know if John, if you have a different opinion on that.
No, I mean, I think it may be an all hands effort to get to that, goal of everyone. But I think, one of the other unknowns, and I'll give an unknown for once, is around, what is it going to look like under the data sharing to know if a person has already been screened, and, if your organization is going to do that screening, but someone else has already done it. And what is that flow going to look like? I think there's still some questions about that, because we certainly don't want to ask a person to do a screening if they just had it done. And we don't want to have an organization take time just to be not reimbursed because it was just recently done. So I think there are still some questions about that. But yeah, I think from my perspective, I think we're going to need to think about how, where is a particular individual most connected and how can they best be supported without just getting, you know, shunted around the system.
Okay, thank you.
I have a question. I'm curious about the timetable. I mean, you said this is through 2027, but I'm not sure what ends in 2027 and whether or not, I don't know, the whole thing. I mean, it sounds like a bureaucratic nightmare. And I mean, most of the other people here are used to dealing with all these different sources of funding and so forth. But as just as a lowly government worker, it just seems crazy, and just the whole idea of how long it's going to take for this all to really be functional and for people to actually get reimbursed and get certified or whatever. It's just, I don't know. Do you have any sense of that?
Yes to all of that. I heard rumors that upon the successful approval from the feds of the waiver that the state began work on the extension, but that was just a rumor. I don't know if that's true. You're right, though. I think it's very, if you read the materials for the applicants for social care lead, there's a very tight timeline for what they're going to be asked to do. And, Lara already referenced how, there's really not realistic that the state's going to even award it for that timeline to be able to be in place. So I think those are valid concerns, certainly.
This is Sue Ellen. I'd just like to comment on that from, being on the executive committee with the previous DSRIP round. Actually, this one sounds more organized than the previous one. I think that, with it being there's structure, and it seems as though, when it's rolled out, everybody's going to be rolling it out in a similar way. I think that seems more organized than the previous round that we had, which was more innovative, but yet there was more I think chaos with it. And I think that there's going to be more structure and governance at the state level for this one, if I'm interpreting it correctly. I'm not seeing it as a negative.
Yeah, I think you're right, Sue Ellen. And then there's still that question about what is the hero's role in kind of setting the statewide policies, perhaps, or setting some of the, kind of the standards. So yeah, I think that's probably a good read.
Is there any role for the managed care insurance companies in this, or how will they be integrated into the process? And how many of them are there?
I believe there's 4 in the Southern Tier region. Did I get that right, John?
I'll defer to you on that. Yeah.
There's 4 in the Southern Tier region. I'm not going to rattle them off because I'll probably get it wrong. They have they will be allowed to do screening and navigation. They wouldn't get reimbursed for it. But I think we're not really expecting that to be a service that they particularly provide. So their role will primarily be in providing data and then also providing payments to the social care network lead. So they're vitally a vital component of this system, but I don't think necessarily in the provision of services.
I think we're hitting our time, but I'm certainly willing to stick around for a few more minutes if anyone wants to talk some more.
Same here. And I'm probably supposed to say when the next meeting is, but I'm going to defer to Nicole on that.
Yes, we now have our summer break. So we'll meet again on September 9th.
Will
And
there
that
be
will
any time, excuse me, will there be any time in that meeting to ask like follow-up questions or for you to tell us more about what's going on?
I would certainly expect at that meeting, we will know who the SCN is. And so we would certainly do some component of that, have an update, fingers crossed, right, John?
Yeah, there are a variety of things, you know, if you keep your eyes posted, maybe we'll ask Nicole to send out. There are a variety of things that'll be happening through the summer. I know, for example, like the Care Compass Network folks are going to be having I think on Wednesday, a webinar about community-based organization readiness. So we may be able to send out even during the summer some more information. I would also imagine that whatever entity is selected as the lead will start their big recruitment push. So there'll probably be a lot of information coming out around that as well. So we can be sure to continue to send to the council and the list of folks at this meeting, you know, anything that comes our way. So you can choose to do that if you'd like.
John and Laura, very nice presentation. Thank you. Very
Thank you.
informative.
Yeah, thanks, Will.
Yeah.
It's pretty complicated stuff. Sorry to try to bite size it if we can.
You did a great job breaking it down for us. Thank you.
We do have one question, looks like to Lara.
Yep. Do
Yeah.
they have the capability and authority to deny payments? So they're not the ones that are actually paying the CBOs directly, right? So like they're going to be sending per member per month payments. So if anything, it would be like denying like whether a member can, you know, count towards the per member per month payment. But I don't think that I think it would be the SCN would be the bad guy denying payments, right?
Yeah, and I think this is an area where the state may have learned from previous 1115 projects in other states. Like I think it was maybe California had one where the each social care service was reviewed basically like a healthcare claim and then rejected or accepted by the payer in that more traditional model. And it sounded like that was much more of a terrible slog. And so it does seem like that's not exactly the approach that they're taking here.
Yeah, I could
Good
say
luck to both of you.
Oh. Thank you. Was that a long enough awkward pause to say, oh, question? See, it's good to pause. Can you share at all the background of this project again? What problems are there? How is this model predicted to be better? Whoa, that's like a whole presentation, but I'm going to punt that one to John.
Yeah, I think in just like a moment, I think what I would say is, you know, there are a number of things that lead to this, you know, from the state's perspective, as well as why we might care here locally. So one is that Medicaid is tremendously expensive. It's, you know, a huge undertaking, both at the federal level and then at various different ways, cost sharing at the state and even local levels. So there's a huge cost, and reducing those costs is a major driver for all of this Medicaid reform. One of the things I didn't talk about at the beginning was that all the waivers have to be revenue neutral or better. So you got to save at least as much money as you use. It's not just free extra money to do with as you please. And then you have your whole remaining Medicaid allocation to cover the gap. So that's part of it. There is a motion, you know, across the healthcare landscape to think about how do we move away from a fee-for-service model to what they call value-based payments. So how do you pay for the performance and pay for better outcomes? From a local organization standpoint, you think about, we have a pretty big disparity maybe between groups of different races, folks of different ages, people with different health conditions, people who are housed versus unhoused. There's lots of different health disparities, and so there may be different costs at different points. Is one individual using emergency room care when they could be better supported by traditional primary care before it gets to that emergency room point? And then this, kind of over my time here in Tompkins County, the last 10 years, right? Really a shift in how we understand health-related social needs or social determinants of health, and how important these social factors are towards someone's physical health. And so trying to begin to shift some of the spending from just straight clinical to supporting some of the services and the needs that are addressed by local community-based organizations. So I think all of those things working together are what drive toward this project. And and so then the predicted to be better would be, right, if people have their needs met upstream from needing the most expensive care, we should see better outcomes, we should see cost savings, and we should see a progression towards better health equity. Again, it's going to be in the details, going to be how this is rolled out. But in our region, the previous Medicaid redesign, it did reach many of its goals, including the kind of the money savings and some of those outcomes. So there was a lot of progress made towards the identified goals. I don't know if there's anything you'd like to add, Lara. That was a little longer than I wanted to go. But yeah, excellent question. That's gets to the crux of things, Katerina.
All right. I think I'll call it then. Yes. And thank you, John. I think, I continue to learn from listening to you and really appreciate that we've gone through this process side by side, a really challenging application process, and continue to work together really well. And regardless of who becomes the social care network for our region, we'll continue to work together. So
yeah, and I think that's the main message for everyone here is, whatever happens in terms of the different applicants, your Tompkins County network of us, everyone involved with the Health Planning Council and all of us working together, we're all in it still. No one is excluded from this important work.
all right. Well, if I don't see you before September, have a wonderful summer. But I'm sure I'll see you in one form or another.
Thank you all. Thanks for the
Thank
great
you.
questions.
Thank you.